Good afternoon, everybody. Actually, I don't have kids, but I do have another engagement. Mine only have 4 legs. So I am a senior consultant in Southern California for Kaiser. I do run our mobile integrated health strategy, and we have actually what's called a interregional work group, which are members, representatives from every region in Kaiser. And we're all pretty collaborative on this effort, working together. I am going to try and pass through a bunch of slides to save on time. Normally I would actually start this out by talking a little bit about my family, because at my heart of this, I came from EMS many years ago as starting as an EMT, and then moved to the federal government, where I worked on federal reform of EMS, and when that failed, I'm now trying it from another vantage point. So you're going to see some kind of funny slides for a while. This is my family. I come from a really large family in Kansas. They are what I call Kaiser's nightmare. They are all frequent utilizers of the ED for all the wrong reasons. Here are many of them: diabetes, home health, lack in home health coverage, just not going to the doctor, period. My poor grandmother has constant problems with UTIs, doesn't take care of them, just goes to the ED instead. This is my cat scratching records, which is to see if you're all awake. Everyone awake? Anyone see a cat scratching records? That's one of my children. So you get the point. And the last one is my favorite one for all my cousins, and they go to the emergency department far more often than anyone should. So just a reminder that the whole point of this is to get folks to where they need to be so that we can use EDs for things more like this, right? So that's one of the goals of mobile integrated health. I do believe that different models can actually help all of my family, and that all of these models also reach the triple aim impact. So I'm talking today actually from an interesting perspective, because Kaiser is not just a payer. It's also hospitals, it's also doctors, it's nurses, it's a lot of things. So what I wanted to start out with was sort of just a general overview of the healthcare system as it is for most systems, and then how it is for Kaiser's integrated model. So most systems, you've got a lot of hospitals owned by a lot of different entities. You've got a lot of clinics, specialty care clinics, owned by a bunch of entities. Doctors are owned by all kinds of companies and people. Nurses, paramedics, other care providers are other companies. We've got pharmacies. I forgot labs. And then we have the payers, right? And in the middle of all, and we have the data, which Chris mentioned, which I think is very important. In the middle of all this, we have our patients. And the unfortunate part of the healthcare system today is that the patients are left to navigate all of this, right? So it's up to my uncle to figure out who he needs to see, how to see them, what's paid for, what's not paid for, where to go for care. And so it's no wonder that we end up using the emergency department inappropriately, right? Because it's easy, and it's what people get used to. And in my family, that's why they do it. What this results in is that somebody goes to let's say, to the ED, ends up seeing both a doctor and, of course, some nurses. They order some tests, probably more tests than are needed. They get referred to specialty care clinics, and hopefully eventually at the end of the day they get home. In a normal system, the payer is all over the place, right? They're paying for all the components of this, and people are making incentivized to do things like provide additional testing that may or may not necessarily be needed, and that's how income is generated. So at Kaiser, things are a little different. Because we're integrated, we're connected in ways that a normal system isn't. You know, our doctors, our hospitals, our clinics, our pharmacies, our labs are all integrated, and we're the payer. So what does this mean? This means if you integrate these things, that you take away the extraneous costs for things like unnecessary testing, for unnecessary referral visits, and you get patients to the most appropriate level of care. And from my perspective, the point of mobile integrated health is to get to people to the most appropriate level of care. So we all know the emergency department isn't the most appropriate level for a lot of people who end up there. So Kaiser has a big interest in mobile integrated health, because it actually, our incentive structure within our organization is aligned to the same sort of goals that mobile integrated healthcare is aligned. For a normal system, when you put the paramedic in the middle of the picture, or the community paramedic, There are, as Chris also mentioned, some costs and benefits for a normal system. For the payers, it's a pretty good deal, right? Because you're getting a lower level care provider to provide care in a setting that's cheaper. It's certainly cheaper than the emergency department, no matter where you're treating them, except for maybe some specialty clinics. For the hospitals, as Chris also mentioned, there are pros and cons. It's good to have your EDs less crowded. It's bad to have revenue loss. And for a lot of doctors and care providers, it's not such a great deal unless you're one of the care providers where the care is being delivered. For Kaiser, again, it's different. So it increases our opportunities to provide patients care in their home, which is a great thing. It creates cost savings to our system. If we can, for every ED visit that we can stop from happening, that is a huge cost savings for us. For every ED visit we can stop our members to going to other EDs is an even larger cost saving for us. And also for us, we have, as many of you know, if you work anywhere in Southern California, really bad problems with ED overcrowding and wall time here. So this really helps us as well. So how is Kaiser working with community paramedicine and mobile integrated health? In a couple of ways, and I want to make this distinction because everyone is probably waiting for me to talk about the money, right? So we really do have to think to Matt's point about incentive structures. So Kaiser's incentivized to buy into the mobile integrated health model, but we are also a little different in the way that we fund things within Kaiser. So we have an organization, part of our organization is called Community Benefit. So if we're working with an organization that provides a benefit that provides more of a benefit to the community than it does specifically to Kaiser members, we fund those things through community benefit grants. If a program is designed to only touch Kaiser members, then we fund it through a different funding channel. And that's really important for mobile integrated health because we have two great opportunities. So for the 911 or fire-based systems, for like an alternative destination transport, Kaiser can be an urgent care receiving facility for one of those, but there are also going to be other receiving facilities outside of Kaiser. It's not just going to be that you're bringing patients to Kaiser. For treat and release and treat and refer type programs as well, if it's based off of a 911 call and someone's calling 911 and it's, say, a Kaiser member is 1 in 50 of the patients that your program is seeing, that's really a community benefit for us because it's not really valuable to us to fund a program that's seeing 49 other patients and 1 Kaiser member. However, we're also working with a couple of fire departments and looking at how we can use their community paramedics downtime to specifically address Kaiser members. So we're giving them, we're cross-listing our high utilizers with their high utilizers, and then when their community paramedics have downtime, they're doing pre-scheduled visits with them. So I just want to make clear there's multiple opportunities here. I'll gloss over this. We're working with a bunch of fire departments in Southern California right now. The other way we would do this would be directly through an ambulance company, where we would partner, which is what we've done in the Northwest region for Kaiser, where we would partner with an ambulance company, and that unit would be specifically designed only for Kaiser. So instead of being based in the community, it would be really a partnership between us and an ambulance company. I want to make very clear that these are not mutually exclusive at all. In fact, I think the win for mobile integrated health in the future is having both of these things going on at the same time. Because if we can take care of our members, we free up the opportunity for fire-based systems to be taking care of everyone else. And there's a lot of everyone else out there who needs to be taken care of. So we're supportive of both. And again, it's just a matter of how the funding streams within Kaiser and how we partner with outside organizations. The other thing I do want to say about this is when you think about the future of mobile integrated health, the one thing we're not doing very well right now is engaging with health plans. So I think a big takeaway today for the fire departments is if you want to engage with health plans, you have to understand that this is our incentive structure, and it will be that incentive structure for every health plan. So the win would be if you got 5 of us into the room and said, if you all chip in, instead of coming to Kaiser and saying, we want you to fund another unit. And we say, well, you're only seeing 1 in 50 patients, so how do we justify paying for the rest of you? So one option is we go to a community benefit and we say this is a community benefit and we can fund it through a grant. But if every fire department in Los Angeles County came to us, there's no way we would be able to say yes. So the second option would be you get a bunch more payers in the room and you say collectively, look, if you all chipped in a little bit, we could fund another unit. Now you've got a bigger win because you're helping, the incentive structure is aligned, you're helping everyone, but we're chipping in a smaller amount for the same kind of return. So I think what we really need to do is figure out how do we generate that conversation with other payers. And I'm clearly not the right person to do that because no payer wants to talk to me about their data and who their membership is because we're competitors. But I do think as a community, we need to figure out how to generate those conversations. I also just wanted to accent something Chris said about data. So the other thing we're doing a little different, I think, than most other organizations is that we're not choosing a solution before we identify the problem. So when my boss asked me to take this job, I said, yep, I will come do a strategy for you if we can actually start from the other direction and say, I'm not sure mobile integrated health is the right answer. Let's figure out what problem we're trying to solve, and let's use mobile integrated health as an option. So this is what we're doing. We're doing what's called ED high utilizers work groups. And we have 12 facilities in Southern California. And what we're doing is we're pulling together ED docs, ED nurses, quality improvement staff, data analysts, and administrators into a room and having them decide what problem they want to solve. Because there are a lot of them, right? You could solve outside medical costs. You could solve who are the highest cost utilizers of your ED. You could solve who are your highest volume utilizers of the ED. There's a lot of questions out there, and we need to make sure that we're providing a solution that answers the question. So the other good part about this is it's driven by our people. So they're telling us this is our facility, this is the problem we want to solve, help us do that. And the other thing that's really different about this process is that we're using a type of data analytics that's pretty new and that we actually kind of made up, myself and one of our analysts, that looks at how can we think differently about our data in order to figure out what patient populations we actually need to address. So the way this works is that we've piloted it in one place so far. It's been in Panorama City. Their problem is, the problem they want to solve is that their EDs are really overcrowded all the time. They want to get utilizers out of the ED who could be better treated somewhere else. So that's the question we started with. So most of you are used to seeing your data like this, right? You get this huge Excel spreadsheet. Some analyst sends you a table, and it says, oh, look, your highest utilizers had X number of visits per Y number of time. So what we did instead, for those of you who may or may not know this program, there's a program called Tableau. And you can take this Excel sheet, and you can throw it in Tableau, and it will kick this out to you. And this is one, and I'm going to take you through a couple of examples. But what this is looking at the bottom row are medical reference numbers so those are each patient's. The side row are the number of visits they had per year. So what you're looking at now, instead of picking an arbitrary number and saying, oh, we'll call high utilizers people who came to the ED over 6 times, what we're doing is letting our data drive those things. So what you see here is 3 standard deviations of the mean is the gray bar, and that's 6 visits. So we said, okay, anything over 3 standard deviations of the mean, we're going to call a high utilizer. But then we saw that you've got all these outliers at the top, right? We're saying, well, what's up with that? Who are those people? So there's sort of another natural break in the data, and we called these super high utilizers. We chart reviewed these people, and not surprisingly, they came back primarily as mental health, substance abuse, and homeless. So what we're doing as a region is actually taking that and putting it aside and saying, we're going to address this issue as a separate issue, not an issue for Panorama City to figure out how to decrease utilization of their ED. Also included in this group were people that had like terminal cancer, folks who are just not going to keep out of the ED. So not useful for us to try and develop a program that's, if we're trying to, again, going back to the problem we're trying to solve, looking at the volume of folks that we had. Here are the other amazing things about Tableau. So I'm going to take you through what ended up being the thought analysis process that the Panorama City group went to identify the members that they wanted to try and address. So first, we looked at everybody that had utilized in a year. Then we kept only patients who lived in the Panorama City service area. So people who were visiting that ED from outside, you could be visiting from Portland and end up in their ED. We said we just want to look at the people who are coming who live in this area. Then we said we were going to actually just look at the San Fernando Valley of Panorama City. Then we said we're only going to look at people who are 18 and older because we think it's easier to intervene on those people. And we also found that actually a lot of the younger populations who were coming in were associated with a certain time of day, which happened to be right around the time our urgent care is closed. So it's likely that people under 18 are coming in with their parents. Then we said we're going to only try and intervene on KP members because we think it's easier to create interventions within KP to do so. Then we looked at who were either discharged to home or otherwise left without being seen. Because these are the people that we think, if we're going to use a program to try and prevent folks from coming to the ED who don't need to be there, probably the people who are coming in and then going home are the easier ones to intervene on. We also stratified by discharge diagnoses and whether they arrived in an ambulance or not. Our group decided that whether or not they arrived in an ambulance was actually irrelevant because people, as we've heard over and over today, use 911, for all kinds of reasons, whether they need it or not. So we left people who arrived in an ambulance or not in the group. And then we stratified by whether they were high utilizers or not. So what we ended up with was a targeted group of folks. But our group from Paramedicine said, you know what, we want to make sure that we know who these populations really are. And we did a chart review, which we just did last week to look at what are really all of the conditions beyond just the discharge diagnoses. I also wanted to mention that was a very streamlined look at the way the data ended up looking. We went through, the cool thing about Tableau is you can do real-time hypothesis analysis. So it would be like they would say, here's a good example. They thought that older patients would have longer ED stays. So we went down this rabbit hole of trying to figure out if that was true. And in Tableau, instead of having to do all this long data analysis, you can do it by a click. You can literally click on it. I could click on one of those bars and it would pull up all the patients who fall underneath those bars. You can ask questions and answer them in real time. So we went through a lot of questions that ended up in dead ends before we got to what I just showed you. There were also things that were nice to know. So we asked, do things like race and ethnicity make a difference? Do things like language make a difference? Do things like age make a difference? And it turned out things were helpful to know, but they didn't actually contribute to the patient narrowing of the patient population. And finally, what we ended up looking at too, we also have a predicted high utilizers program at Kaiser, but it's really focused on the predicted high utilizers of cost. So it's the top 1% of cost. And again, I had to remind our group, what we're trying to do in this pilot is narrow down the volume and not necessarily the cost. So cost will be a factor that comes in at the very end when we determine which patients to try and address. But we did want to take a look at it to see, are these cross-listing with our cost high utilizers? So that's the process that we're going through in Kaiser, and the result of that will be each facility will have identified the problem they're trying to solve, and then they will have a patient population identified for an intervention. What we'll do after that is we're going to map all the assets that KP already has. So we have a bunch of programs that are designed for like CHF patients or COPD patients or diabetics. If it happens to be that those programs aren't addressing the needs of our patients, that's a QI project, right? We're not going to create a mobile integrated health program to fix a broken program. We want to create a mobile integrated health program that targets an audience that needs targeting. So the end of this process will be we'll have identified a subset of patients that where there's a gap in care and that we believe mobile integrated health is a good solution for, and that's what we'll develop the program around for Panorama City. This will be different for every facility across Southern California because, as someone just mentioned, the demographics and geography are so different as you move across Southern California. You have everything from Skid Row and inner city South Central LA all the way out to Kern County and to, we have it all. So it really does depend on where you are. And I want to actually close on a thought that Chris brought up and I think is incredibly important. So I came here from working 6 years in the federal government where I worked really hard to get EMS moved out of the Department of Transportation because I thought policy was the way to make things move. Now that I've been to Kaiser, I firmly believe that data is the way that we get EMS to be an integrated part of the healthcare system. So what I've realized from working in Kaiser is that docs don't appreciate everything that we see when we walk into a patient's home. So everyone's trying to figure out social determinants right now. How do we figure out who our patients are? What are their social needs? I bet you every paramedic in this room could tell you most of the social needs of your frequent flyers. You see the inside of their house. You see what's in their fridge. You see they have mold on their ceiling. You see they have 35 cats. The problem is that data doesn't get transmitted out of your brains and into their patient's EHR. So a big part of this is trying to figure out how do we share data? And I don't mean just share data between health plans or between hospitals or between fire departments. I mean all of us, and all the way down to the criminal justice system, the schools. We have huge opportunities to use these programs, but we have to start being more transparent about the way we share data. The other piece of this is just rote integration. So by integration, what I mean is, how do we get your EMS EHR to talk to our patient's EHR? Because until we do that, you guys are providing our patients a service, and we don't really know what that service is and how it plays into the patient's larger care plan. Now, as mobile integrated health programs are getting developed, this is going to be more and more important. Because if you're seeing my Kaiser member 6 times and you're providing a bunch of interventions to them, and that's not transmitting over to their care plan in Kaiser, now we have a problem, because we're probably providing them with additional services that they don't need anymore, but we don't know that because we're not aware of what you guys are doing in the field and how that's affecting patient outcomes. So again, this is a huge passion of mine, and I'm at Kaiser because I think we have a good system that can actually try and push the needle forward, and we're very excited to be able to work with all of you as we move forward on these initiatives and figure out ways to be working together in a better way. Thanks.